Sarah Jane said, my name. Oh, all right. I had to okay the recording. So yes, I am here at Bethany. I've been a therapist with the refugee and asylum population with our healing center, which is survivors of torture, for over 4 years. Please bear with me. I took a 3-hour workshop seminar and put it into a lunch and learn. I was very proud of myself, but then I realized I did not change out refugee for new American. So that was not intentional. That was, so the next time we do this, that will be switched out, but please know my heart is in the same area of wanting everyone to feel like they have progress and they have the ability to move towards their goals, both mentally, emotionally, and physically. So having said that, let's dive in. I'm going to share the screen. And I'm going to stop share because I don't want to have to like look to the other screen and it wasn't. All right, let's try this again. There we go. Why is it doing that? Jessica, what's happening?
I don't know. I never have that come up when I do this.
It's crazy. All right. Maybe we should like cut this part of the recording out.
Do you have two screens, Jennifer?
I do. I'm unplugging my second screen. So
you could open the PowerPoint twice, and on the one that you share, just open it as a normal slideshow, and then on your other monitor, open it with your presenter notes, if you have notes.
Okay, it's not. There we go. There we go. How's that? Okay. I'm gonna move you guys over here so I can read. Okay, so that is the QR code that Sarah Jane was talking about. If you do not click the link in chat, you can do the QR code. You just put your phone up to it, and then it'll take you right to the Google Doc to sign in to say that you were here. But we're just going to talk about mental health and trauma with refugees and new Americans. I labeled this 101. Some of it's basic, but I didn't want to assume. I want to get everybody on the same page. So there's going to be some review, and then we're just going to kind of dive in to some of the ways that we adapt Western ways of looking at mental health to help accommodate different cultures across the world. So the first thing I want to go over is, why should we even talk about trauma? Why is it a big deal? Well, first of all, the prevalence of trauma, from little t up to complex trauma, right? So there's a whole span of trauma, just leaving everything you know behind, leaving family, leaving language, leaving traditions. That is a type of trauma. You don't even have to have the torture on top of that, or the lack of food or anything. That is a type of trauma. It knows no boundaries. So it crosses economic thresholds, it crosses cultures, it crosses genders. There's no boundary to trauma. It leaks into every area of every human life. There's a wide definition of trauma, which we'll go over. It affects yourself, your community, and it affects us. I'm calling us responders, people who have a passion to help those who are in trauma. So it affects us too. We're going to talk about secondary trauma and secondary PTSD. And if we have a role as a community responder or a resource facilitator, we should know about trauma and how it comes out, either through physical means, through emotional, and why it limits people. When we say, why aren't you going to work? Why aren't you, like, what about it is limiting refugees and new Americans to move forward in their goals? So here's some key definitions. Trauma is a terrifying experience, threatening life physically, physical integrity, overwhelming ability to cope, and leaving a helpless feeling. So the refugee, which we've talked about, or a New America, is a person who has fled their country of origin and is unable or unwilling to return due to a well-founded fear. Jessica did a great job in our first Lunch and Learn going over this, and that it's they're being persecuted for reasons of race, religion, nationality, membership of a particular social group, or political opinion. And so when you take that and you add it to the trauma, there's some different examples. So we have acute trauma, which could be a car accident, being assaulted in the community, death of a parent. It's a one-time event that then affects us more than that one time. Then there's chronic. Chronic is trauma that continuously happens, either military service, repeated sexual or physical abuse, child, verbal abuse, different things like that, ways that you can't escape the trauma. It's still there and it occurs day after day after day. And then there's complex. Complex trauma usually is defined within the youth parameters of a child, but it's broadening its scope in the recent years, but it's exposure to multiple traumatic events. So where chronic is like the same type of trauma over and over and over again, complex are different types of trauma. So you may have, someone hit you, then you turn around and now you're homeless, and then you turn around and it's like multiple traumas over and over again. And so then childhood traumatic or continuous traumatic stress, that's where more events experienced and they're longer. And the effects will be, I'm sorry, I cut that off. The more pervasive the effects will be. And then you've got the post-traumatic stress disorders. Those are a clinical diagnosis, which is exposure to a traumatic event, followed by re-experiencing, avoidance, negative changes in mood and thoughts, changes in arousal or reactivity of at least a month that affects an individual's life, not due to any other factor. So let's talk about some of the examples. So we have abuse, and there's some examples there of abuse. I do want you to note that any number of events can be traumatic. So what's important is not the event itself, but one's perception. A couple years ago, somebody told me someone's perception is our reality, and that's really stuck true with me. A client can be sitting in my room and they can be saying that they are experiencing trauma because they don't like their third shift job. And to me, I'm like, well, it's a job, like you're making money, like it's helping you pay the rent. But to them, it's traumatic. And so because their whole life is upside down now. So the perception of the client or the individual or the patient or the community member in front of us is our reality. And so we need to step into that reality and put that lens on, and how can we help support them through that traumatic event. I talk many times about we're not going to get over something, we're going to process through it. And in terminology, words do matter because there's definition behind certain words. So there's different effects of trauma. There's immediate trauma, and we hear this all the time: fight, flight, freeze. I'm going to go over the window of tolerance just to kind of keep us all on the same page, because this is significant when dealing with the refugee and New American population, because they don't understand window of tolerance, the concept. And so there needs to be a lot of psychoeducation, which we're going to get into, as to why they feel what they feel, because that then gives them power. Most cultures do not have this emotional, mental dialogue. It's all like physical. And one example would be, I learned from an interpreter that I kept saying, feeling, how are you feeling? What are you feeling now? And the interpreter took me aside after a couple of sessions and said, you know, in our culture, feeling is thought. Feeling and thought kind of are synonyms of each other. So I started switching my language to emotion. What emotion are you feeling? And starting to work on these emotions and telling them, of course, this is how you feel. And really talking to them about, do they shut down? Do they run away? Do they not want to go back and avoid? What are these things when they're dysregulated? Or are you angry and yelling or throwing things or driving really fast? The more I can explain that to somebody who this isn't their way of thinking, the more power I'm giving them, because then they can start to acknowledge when there's signs. Oh, this is a sign I'm not doing well. So how do I find myself to get back into the window of tolerance? And if I were to go to a therapist, she wouldn't necessarily say, where are you at in your window of tolerance? But I've grown up knowing if I get angry, these are the things my parents taught me to do to bring myself back to homeostasis. Or if I want to run and hide and sleep, these are ways to go outside and play. And so we've grown up in the Western culture of organically understanding the window of tolerance, where refugees and new Americans do not. And so just really talking about this gives them power, and it also gives you a step forward in your mental health process with them, of a firm foundation of why they're even coming to therapy. Like you've got to get that buy-in. Okay. All right. So there's just to review. So fight, flight, and freeze response modifies the brain structure. The more they're in it, so if they've been in a refugee camp for 10, 15 years, their brain has changed. And so just knowing that if you're helping somebody is to understand that that logic, that connection between right and left brain has changed. And now they're going to have a heightened level of whatever tolerance they go towards, whether it's fight, flight, or freeze. And their internal alarm system is on all the time. It never turns off. And so how do you help someone understand what off means? When you have been alert for so long, when you turn that alert system off, how do they feel safe with not being alert, right? If they have had to be alert 24/7 and you're telling them they can turn that off, that doesn't feel safe to them. That feels weird. It feels like I'm doing nothing. It feels so vulnerable. So what are like these very gentle baby steps that we can calm that alarm system down so it becomes more normalized to not be alert? Because right now it's normal for them to be alert. So how can we flip-flop that? And so just understanding what it means for them to feel safe is a key component. And then there's some, I call them obvious symptoms, flashbacks, dissociation, avoiding triggers, depression, aggression, physical symptoms like stomach aches, headaches, sadness, crying. The reason these are obvious ones because they're outward. So you can actually see them when they happen. There's a change. And then there's subtle symptoms. So those are inattention, inability to cope with stressors, avoidance, and that can be physical or emotional. Okay, so what are the lasting effects to trauma? And the reason I'm talking about this is, again, many of the clients or patients that we will be seeing have already gone through years, if not decades, of sitting in this trauma bowl, basically. So the long-term trauma, that, like I said, the brain is in a state of constant hyperarousal. So we need to decide or figure out, how do we help expand the safe space? So number one, we have to figure out, what does safe mean to them? One person, my thoughts are safe is like an apartment with locks and, a roof over your head. And the person said, no, being alone was not safe. Safe to her was community. Safe to her was sitting in a room with 5 other people or hearing the breathing of her children, knowing they were safe. So I had to learn as a therapist, how do I step back and allow a client to tell me what safe means to them? And once I know what safe means, how do I expand that and help them see with a different lens? Like I said, everything unknown feels unsafe. Responses seem out of proportion to certain situations. Trauma symptoms are the brain's effort to make safety out of what feels unsafe. So they're going to dissociate if they feel unsafe. They're going to get angry or triggered if they feel unsafe. They're going to run and hide or avoid work if they feel unsafe. So our clients and patients are not bad. They're not wanting to disrespect us. It's trauma trying to find safety. And so they're going to always default to their weakness. And their weakness is however they react when they're triggered. You know, if their weakness is anger, if their weakness is substance use, if their weakness is crying all the time. And I say weakness not as a bad thing. I say it as like a coping skill that they do to help themselves when no one's looking. Okay, so the long-term development, when safety and security do not closely follow a traumatic event, the brain remains in that heightened response. So if they witness something in front of them, or they get taken, you know, maybe they came over, but their spouse didn't, and it's this traumatic event, and nobody comes alongside them, they may do the Maslow's hierarchy where they have food and a roof and clothes on their back, but they don't speak to their heart. The brain remains in that heightened response. And then they start developing patterns of behavior based on that heightened response. And we talked about this. So doing things to make the environment safe based on history may be maladaptive. Changing what feels uncontrollable into a controlled environment in their own mind. So these are things that they do to help themselves feel safe. They may invite people into their apartment that aren't the best because they want to be with somebody and they feel safe that way, but that's not good for them, because maybe that person isn't safe. Maybe that person takes advantage of them, or they give everything they have. I had one client who was a people pleaser, and she didn't realize that she shouldn't give her kids to somebody else to put on their taxes. So her friend was getting all the tax refund money from my client's children, and my client was getting nothing because she didn't realize the deductible, right? So her friend had come over a couple years before, and so, but she wanted that friendship, and so she felt like this was a way to feel safe and have a friend, and she needed a ride to work, and she needed this. And so these are the things that I consider maladaptive. Also, affective trauma is a limited ability to trust others, and inability to manage emotions effectively or to adjust to changes. And these are just common things that we see in trauma in general. Not even they're in general to human beings. They're not like specific to any people group. Okay, so triggers and trauma reminders. Just remember, it's something that causes a person to feel unsafe by reminding consciously or subconsciously of their trauma. So there's sensory triggers: sight, smell, touch, sound, taste. This is important when dealing with the population that we work with, because they have a different lens, a different filter. And so when they hear shouting, they might think, someone's coming to break in. When they smell a certain smell, like burning, let's say they walk into a volunteer's home and the volunteer has a fire going and they smell that wood smell, and it brings them back to their village was burned down. So there's sight. This happens especially with my Congolese. There's different tribes that are against each other. And so even though I have a Kenya-Rwanda speaking interpreter, he might be from a different tribe, and they can tell based by height, facial structure. And so they walk into my office and they see somebody that's really tall and slim and thin, and that their tribe is, you know, short and a little hefty, and they just don't open up. They're like, no, I can't do it. I know that gentleman didn't kill my wife, but I can't. The sight of him, I just can't. The sound of his dialect or his accent, I can't. Like, it brings it all back. So those are key things to remember. There's environmental triggers, familiar locations, similar situations. There's interpersonal, which I just talked about, tall or big person, authority figure, an unfriendly adult, a friendly adult. So that's kind of trauma in general, an overview. Now, how do we create safety for our clients or our patients? We need to remember that everyone carries what's called an invisible suitcase. And that's how a person carries their belief system. And everybody has an individual belief system. There are similarities between all of us, but they are unique based on our circumstances. If you think back to any class that you took on nature versus nurture, it's kind of like a full up like merging of everything we've ever seen or heard growing up, as well as what we were born with. And so complex and chronic trauma reshapes the way that we view the world and those around us. It changes the way we interpret messages. And at their core, it changes their beliefs about their own value, their own safety, and who is safe. Again, coming back to, we've got to figure out what is the client feeling and thinking so that we can step into their suitcase rather than pulling them into ours. It is not safe in our world. They've created a whole world for themselves that they believe is safe. And so we need to step into their world and work within that. So our response has a significant impact on their interpretation of the event they're struggling with. So some of the things to think about, instead, we're not going to say what's wrong with you, but in our heads, we need to think, instead of saying what's wrong with the client, we need to think about, like, what happened to you? Like, what brought this sense of anger? What brought about this sense of loneliness or depression, instead of what is wrong with you? It helps us be able to have a more compassionate lens, as well as a more objective lens. We also need to think about how can we help them with the beliefs and expectations about themselves. They do a lot of comparison. Many of the cultures compare community member to community member. Well, if they can have 10 children and work in a factory and have a car and etc., why I have 2 children and I can't get out of bed? And they do a lot of comparison. And even ourselves, we do that. But there's this huge, because they don't speak English as their first language, because they're needing to find some sort of way of communication about what is normal, they are comparing everything. And so it's a heightened level of comparison. So really exploring, what are the beliefs and expectations about self? Another thing too is sometimes they're thinking, I'm unlovable. Maybe I'm stupid. Maybe I can never learn. I have some older clients who are, I can't learn English. And because I can't learn English, I can't ride the bus. I can't do this. I can't do that. So therefore, I'm worth nothing. I should just be thrown away. I can't do anything. I used to be the chief of my village, and now I'm sitting at home 24/7. Nobody's talking to me, and I can't even go to the store and buy a thing of rice on my own. So you can see how this kind of compounds their value. No one loves me. It's my fault. My fault sometimes happens a lot with reunification cases as well, where the spouse comes here, the children are with them, but the other person is back home. Their kids are saying, it's your fault, dad's not here. It's your fault, mom's not here. So not only are they internally thinking, why didn't I do something different? Their children are now reinforcing that. So these are all things to think about with this invisible suitcase. What is creating their belief system that we can step into and help support them and help remodel that in a way that doesn't take away their beliefs, but helps them see it and make a choice about how they want to move forward. So these are some trauma-informed strategies of how to repack the suitcase. So you're going to want to really question the messages and try to dig in, is it really accurate? So in the case of one of my clients, the children they're saying, I miss dad. It's your fault. Why isn't dad here? We love dad. We don't love you. She's working third shift. She never sees her kids anyway, so she can't reinforce that I'm mom. I love you. I'm here for you. So we really talk about, like, was it your fault? What is the system of reunification? Look at the governments. Let's talk about this like path to reunification. Like, look at the 10 people that it takes to reunify. Are you in control of any of those 10 people? No. Is Bethany in control of any? No, we're only in control of 1 out of the 10. You know, how's treetops? How is this? You know, no. So we have this little slice of the pie or this little slice of the path. So now what can we do while we're waiting? What can we do to help our children in their grief? And then we talk about grief. You know, you're right. Your children are upset. You're upset. You are going through almost as if your husband died. And so when someone dies in your community, what does that look like? Like, how does your community grieve? And then we just start talking about, do you see that in your own life right now? Yes, I do. Okay, so that's again creating that safe space for them, that what they're feeling is normal, even in their community, not necessarily in the United States, not in Western culture, but we find out what is normal for that feeling or emotion in their community, and then how can we support them in that. Again, I think all of us know this. You can do it. Affirm they are capable. I like to look back and say, oh my goodness, you are a mom of 2 and you crossed the world. Like, I can barely pack my suitcase without a panic attack and cross the city, you know? So let's look at, what did you do to get here, and look how capable you are. And I sometimes self-disclose a time that I didn't feel capable, and to affirm them that they are capable. And many times, no, I had to, I was forced to. And then that's an amazing open door to talk about choice. Okay, no, yes, they said you had to go here or else. You chose this because you chose life, but you had choice. Like, you could have chosen to be arrested, or you could have chosen to be this. And so look how amazing you did at surviving. You chose survival. And so just in baby steps of choice, and that's kind of the bottom, give them choices. If you know anything about motivational interviewing, that's kind of what therapy feels like with refugees and new Americans. It's allowing them to understand that they have choice. And one person I went to a workshop mentioned that he was working with this homeless person, and he said, choices suck right now for you, but you still have choice. So you can choose to live under the bridge and avoid the rainstorm, or you can choose to sleep on the corner and get pelted with rain. Yes, that sucks. That sucks that those are your 2 choices, but you still have choice. So there's a lie in saying you don't have choices. They're crappy choices, and then they affirm that they're crappy and they sit in the ashes with their client. But they're forming that choice. And then the more you affirm the choice, which our clients feel like they have no choice, they feel like their voice has been taken. And they and many times they speak to me about they're just going with the flow. They're just signing paperwork. They're just doing whatever people tell them. And that's where this vulnerability steps in. And so by talking to them about choice, by talking to them about you have a right to know everything you sign. You have a right to have an interpreter. You have a right to do this. And working on that education as well as affirming that what they're feeling is true, brings about power for them. Another thing is reacting consistently. We're teaching them that we can be trusted. So I talk a lot about what does trust mean to you, and how do you know someone's trustworthy? Again, this is all getting the perspective from that person that's sitting in front of you. So again, you're giving them the power to give you knowledge so that you can use that. Another thing is don't respond negatively to their negative reactions. You teach them how their value is not based on their behavior. So many times they'll get mad at me because I'm not paying their rent. I'm sorry, I can't pay your rent. But you say you care about me. You say that you don't want me out on the street. Why can't you help? Bethany is a big organization in their mind. I'm like, okay, behind the scenes, yeah. But why can't you pay my rent? And so you're right. It sucks that you're going through this. You can be angry at me. You can be frustrated at me, and that's okay because emotions are real. I care about you, and I'm in pain too that I can't write you a rent check. And so just allowing them to be who they are, and then not responding in a negative way. So we talked about safety is key. We talked about like one thing is just continue to use their name rather than avoid their name. Really work on, like, I have a really hard time pronouncing my own name, and it's easy. I make that as a joke, but I have to work really hard on the 13, 14 different cultures and pronouncing names right. And I can't say certain letters certain ways. But I work really hard, and that's a way to show that I care and I love and that they're important. It's very basic, but it works. And then just understand their cultural interactions. I call it cultural whiplash for me because I can go from being in the Southeast Asian culture in the morning and then Middle Eastern culture in the middle of the day and end up with the African Congolese culture in the afternoon. Some of them want to shake your hand. Some of them give eye contact. Some of them, it's inappropriate for a woman or a man to do eye contact. So I really pay attention to their culture. Even when a case note, appropriate eye contact for one client might be completely different for another, depending on their culture. So really studying what is their cultural backgrounds, how does that relate to how they interact with me as a, Caucasian female. And so that's something to take into account. And then your expectations. I had a Syrian gentleman and I saw his wife and everything was going really well with his wife. And then I saw him too, separately. And we just kept hitting this brick wall. And he admitted to me, he said, everything you said is true, but I can't follow it because you're a woman. And so he really could not get over that cultural foundation that he had of a woman potentially being over a man. And so we affirmed that he was very in his culture. He was, really wanting to embrace it, and that maybe for his progress, it might be best to refer him to a male clinician so that he could continue to work without that barrier. I didn't tell him that's a horrible thing. I didn't, any of that. And I didn't take offense to it either. It's not something that's a make or break moment. It's again goes back to those triggers at the beginning that we talked about. So here's some tips for the office or for Zoom. Safe space. I always talk about that this office is a safe space where they can express themselves. Many cultures do not have this emotional language to describe what they're feeling, and they use behaviors to communicate. So 90% of what I do is not with words, but with how they sit, how they're looking at me, how they greet me the next time we meet. That's usually how I know if the previous session was successful to them. So again, safe space also is a check with you. If you don't feel comfortable with a certain client or a certain patient, number one, self-evaluate. Why aren't you feeling comfortable? Is there something that you need help with your supervisor or with a coworker to work through? Is it something that you just can't get over? Is it your own internal? Maybe somebody hurt you and this client reminds you of that. And so you can't be a safe space. I will self-disclose. It's really hard for me when I have a pregnant client. My husband and I, we went through a lot of infertility and there's a lot of pain there. And so when a client comes in and they're pregnant, it's really, I have to have a lot of self-care. I talk with a supervisor and I'm much better now. But when it first happened, it was a really sore area of my life. And so those are the same things you have to kind of check yourself too, because they will pick up on everything because they don't speak the language. And so they are in a heightened state, remember, so they're like looking for ways to distrust you versus ways to trust you. They're looking for every look at the clock. They're looking for every potential frown, every pause. They are just looking for a way to say, I can't trust you. And so just really having that internal check to make your own office and your own self a safe space. Some ways are develop a common language about feelings and emotions. I do a lot of psychoeducation about emotions and about how the office that they're in is anything can happen, right? They can laugh, they can cry, they can not talk, they can talk, whatever. I'm not going to get upset. I work on giving them control over their feelings rather than being controlled. So I talk to them much about how this room is a place that right now it really sounds like your feelings are running, your emotions are driving the car. They're leading you to react certain ways. What would happen if we turn that around? What would happen if you were in control of your feelings, in control of crying, in control of waking and sleeping? And oh, yes, tell me how to do that. Another way to get people talking that is non-threatening is here at Bethany, we call it a community meeting. So there's 3 questions that we can ask. So number 1 is like, how are you feeling today? It's just a 1-word way of saying I'm feeling supported, I'm feeling tired. What is your goal for today or this week? So my goal for today would be to get through this presentation, to be present, and then who can you ask for help? So these are kind of 3 open-ended questions that you can ask if you're really struggling with a client on how to understand their empty suitcase. And then lastly for this slide, give consistent safety messages. So empathize. If they share something, let them know their behavior makes sense. Be honest if you don't know something, but share that you'll connect with someone. I can't tell you how much trust is built by me saying, you know what, that's a really good question. I am not the expert. I do not have an idea how to do this, but you know what? let me talk to my supervisor, let me talk to your case manager, and let's see if we can figure this out. If you don't hear from me, and I give like a week, if you don't hear from me by this time, here's the office number to check in. I give them the ability to be a part of finding out the answer by calling our office back. Because I don't know, maybe I get sick, maybe I get pulled in. It just happens. So I always give them a way to check back so they're not just relying on me. And then if they do rely on me, that gives me something in the session to talk about, to say, let's work on empowerment. Let's work on that you do have the ability to reach out and talk about, like, we have an interpreter. My job is, your job is to leave a message for our office. My job is to get an interpreter to interpret it. So we both have a job. We're both going to work on doing our jobs, and then we'll come back together and see how we're doing. Another thing is just help them know what's going on and if there's changes. Like I said, they have the hyper aroused brain. They are ready for danger. So explaining anything that's going on is going to be very helpful. I know here we usually get an email that a fire drill is going to happen. So if that happens, I'm like, during the session, if by chance this alarm goes off, nothing is wrong, this is what's happening. Sometimes I get a sinus infection. It does every fall, every spring, because of my allergies and the weather changing, I do. And so sometimes I have to take a deep breath. And so I tell them ahead of time, which my speech teacher would hate, because you never say bad news at the beginning. But I say, you know what, if you see me breathing differently, it's because I can't breathe. It's because my nose is stuffed. So it has nothing to do with you. You've said nothing wrong. I just want to let you know. And it just helps the situation because they're so hyper and trying to figure out what's going on. So always let them know what's happening. If I see a client every other week and I know I'm going on vacation, I try to tell them 2 sessions ahead of time. Hey, we're going to meet next, in 2 weeks, but I want to let you know a month from now, I'm going on vacation. So we'll talk about it next week, but I just want to give you a heads up. So I try my best. Of course, there's things that we can't discuss, but these are extra steps that help somebody who this isn't their culture, right, to adapt, but also to have choice and to be empowered to think through what they're experiencing. And then these are just the 5 states of arousal. There's calm, alert, alarm, fear, terror. So based on what you assess, you want to get them back to calm, and you want to figure out what is a way to get them back to calm. And I express this, over explain processes and procedures, provide information of scheduling change. And then they call it ABC, but I really like to call it BAC because, whoops, get back here. Because if a behavior is an issue, if a case manager is saying, they're just not paying their rent, they're spending all their money on a TV, on this, I don't understand. So think about the behavior first, and then you work backwards and you think about, okay, what is the trigger? Why are they buying a TV? And then based on that trigger, they call it consequences. I like to call it action steps to help them overcome that behavior. So one of the things, if they go out and they buy a TV, well, in session, we talked about that. And it was that they're lonely. They're at home all day and they have nothing to do, especially with COVID. Their English classes were canceled. They couldn't get out of the house. They couldn't ride the bus. They hadn't been taught yet to ride the bus. They were new into the country. They don't speak the language. The church sponsor can't see them. So buying a TV wasn't, I want this huge TV. It was, I'm lonely and I just want something to watch while I'm here at home. And so how can then we work through that to work on budgeting, to work on choices of, okay, well, what about this? What about this? So it's called ABC if you look it up, but I like to call it BAC because it's behavior, trigger, and then I do action steps. We're almost done, people. Doing good. All right, so one thing too is I've talked this till I blue in the face, provide choices, give them as much control in a situation, connect them with a safe support system, discuss and ask what they feel is safe, and then psychoeducate on how to find the safety. And then I want to finish real quick with self-care strategies. When you are working with this clientele, you are going to be taking on a lot of emotional stress yourself, because once they figure out what therapy is for, they fall in love with it because they have been carrying this load for so long. And so they're just going to be like, and they're just going to spill everything out. And so some self-care things, this is from teaching children, but basically teaching anyone who's been traumatized can be exhausting. It can be discouraging, disheartening, but it's also rewarding. So be aware of compassion fatigue or secondary trauma stress. There is a I can send it to Jessica and Sarah Jane to send to the group, but there is an easy way to check in with yourself. It's an assessment of where is your compassion fatigue at? And I usually do it quarterly just to see how I'm doing. And it's like a 20 question thing. And then you're like, oh my gosh, I didn't realize I was here. How do I get back to here? Compassion fatigue is an emotional and physical erosion of what happens when individuals are unable to refuel or regrow after serving others. This can occur in every helping profession. And then secondary trauma stress are the physical symptoms. One thing I started doing last year is I actually take one day a month as a mental health day. So I looked at my ETO or PTO and I said, is it worth it? Yes. So one day a month, it's in the calendar, it is scheduled, nothing can take that away, and I can do whatever I want. My husband, the first time I slept all day, he comes in because he works from home. So he comes in at 3:00 after he's worked 8 to 3 and he's on his 3:00 break. And he's like, you're still in bed? What's wrong? And I'm like, oh, it feels so good. You know, I can read, I can go to a movie, I can go shopping, I can sleep, I can do crafting, I can go work out, whatever, but one day a month. And that's kind of my sanity day to, if I'm having a hard week, sometimes I look at my calendar and go, oh, just got to make it through 4 more days. And then I get this day off and it helps push me through. It's just an idea. And then vicarious trauma results in a more fundamental shift of worldview. So if you have a kiddo or a client that's been abused, the more you work with them, the more you start seeing maybe every child is abused. Maybe every Tutsi Congolese person has been tortured. So you kind of shift a little bit your worldview and make it more of an umbrella of an all or nothing. So an important way to deal with STS is to know yourself, know your limits, know what you can and cannot handle. I know my daughter loves watching crime shows, and we have a select group of crime shows she's allowed to watch. She's 14. I don't want her watching blood and guts and like Criminal Minds, but there are certain days I can't watch those because of what I've dealt with here, because in my office, it's real. And so I will tell her, you know what, I can't handle it. Let's watch something light tonight. So there's certain movies I don't watch. And it's just because I want to protect my heart. Be aware of the physical signs, you know, when you get anxious, when you start to get louder, when you maybe raise your voice, know it's time to take a few deep breaths. Okay. And then seek support. This could be individual support. It could be participating in a social or community group, peers, clergy, mental health professionals, friends, community groups. And then last but not least, just some thoughts on resilience. The truth is people are overwhelmingly resilient. But this can be enhanced by supportive, safe, and consistent people, a strong support network, having talents and abilities appreciated and affirmed, and having control and choice over life. So although we look at the populations we serve as being resilient, that resilience can only carry them so far. And so just remember that we need to not rely just on their resilience, but we need to help enhance it through these criteria. So then I just have references. All right, we did it. We got through it, guys. Thank you so much. So I don't know if we only have like 3 minutes left, but Jessica, do you have anything to add?
I actually have a question for you, if that's okay.
Yeah.
So with my clients who do not identify as New Americans, I tend to use some more body-based interventions like breath work, movement to create that safety in the body. What is your thoughts or experiences with working with New Americans with that kind of work?
Yeah, I do that all the time. So we do
Okay.
safe breathing. We do some yoga moves. I have one gentleman, we do stretches at the beginning of every session, and we actually end with stretching because he gets so tight when he's talking. So yes, definitely. One client, she's actually a teenager. She's 19. We dance. So she picks a dance off of TikTok during the week, and then she loves the fact that I can't dance. And so then she teaches me that dance in session. So don't know what I'm doing, but it's helping. It doesn't matter. So yes, definitely anybody moving. That's yes.
Great. Are there any specific treatment modalities? I'm thinking we have some students here again that either tend to work really well or are not necessarily as appropriate for this group of people.
Specifically, anything that's cognitive, anything that's direct with thinking is not going to be as successful. You're going to want to do things with, CBT, cognitive behavior. You're going to do mindfulness. You're going to want to do like adapting play therapy. TFCBT, trauma informed CBT, also works with this adult population as well. I use EMDR because you can, it's been very successful, not only in helping the left and right brain process, but it's also been successful in overcoming that language barrier, because the brain is doing it in their own language on their own, in that suitcase we talked about, without me being the influencer.
Wonderful. That's very helpful. Thank you.
And the empty chair, you can try the empty chair, but they actually are like, well, he's not there, he's dead. Like, why?
Sure.
So yes, that I've had 1% success with the empty chair model.
Okay. Thank you. That was a wonderful amount of information. I appreciate that you packed it all together for us. I'm sure we could spend another hour with questions and discussion, but I think this was a great start.
Yeah, thank you.
Thank you everyone for joining us. We hope to see those of you who can come back next week. And Jennifer, thank you for sharing with us. I really appreciate your time and energy and wisdom that you offered here today. So we'll